Hi, continuation of our topic on disturbances in locomotion. Next topic is degenerative disorders. Now, when I talk about degenerative disorder, let us understand that this is related to degeneration. Okay, so when I say degeneration, we are talking about aging processes here. We are talking about wear and tear of our joints. Okay, meaning the overuse or use of our joints for prolonged period of time could have led to its destruction already. Hence, it is not very productive as of present. Okay, hence the term degenerative disorder. Okay, we'll talk about osteoarthritis here. So OA as we commonly refer to. So osteoarthritis is the most common among the arthritis. Okay, it could be idiopathic or secondary. So idiopathic, if it is, no cause. Secondary, other illnesses. Characteristic, there is a progressive loss of joint cartilage. Okay, there is synovitis, in other words, inflammation on the fluids which is contained in your synovium, which supposedly lubricates our joint. There will be presence of joint pain. Obviously, arthritis is joint pain. Then you'll have stiffness and then less of joint motion. So this is a typical interphalangeal joint class of a patient with changes associated with osteoarthritis. So notice that there is swelling, okay, and there are deformities that are becoming obvious. Okay, so what are the risk factors? The higher the age, the higher the chances, because of course we're talking about degenerative, okay, age-related. Genetics is there. Excessive or increased body weight could also increase the risk factor. Inactivity, meaning unable to use your joints, and then repetitive use of joints on the other hand. Okay, so class, when I say inactivity, usually these are like joints which are less developed or joints which are becoming torn because they are not used. Okay, so circulation will be inadequate going towards the joint, and then there will be problems on fluid on that joint. Okay, however, continuous stress and repetitive use of your joint would also lead to another story, okay, which would still be your osteoarthritis. Okay, so that would be among your textile mill workers and then your sports participants. So what are the manifestations of this patient? There will be pain and stiffness in the joint. Sciatic nerve pain will be present. There is a decrease in range of motion exercises. There is paresthesia, and your patient would have grating sensation or crepitus. Okay, there will be enlargement of the joint as shown on the hand that I've shown you on the previous slide, and then there will be flexion contractures. In other words, the hand will be flexed or the extremities are flexed on a position that is contracted. Now, what is osteoarthritis in this pathophysiology? So the age that is commonly affected is age 30 and then 50 to 60. More common among women and obese patients. It could be primary or secondary. When I say primary, it is usually idiopathic. When I say secondary, it is related to joint injury or inflammatory processes. Okay, so if you would look at this class, the main reason is joint injury or inflammation, which would give us a cue that when we are talking about osteoarthritis, we rarely or we do not even find systemic signs and symptoms. Okay, now all of these factors combined would lead to the breakdown of articular cartilage. The breakdown of your articular cartilage would lead to progressive damage to the bone. Okay, this progressive damage to the bone would lead to the formation of your osteophytes. So class osteophytes, bone deposits to the joint spaces. Instead of you having synovium there and cartilages there, it would be the osteophytes. And obviously the osteophytes will not be able to help you on movement. Okay, it makes it stiff. It would make the joint spaces narrow, and then it would be decreased in movement. Okay, so what happens is that when there is a breakdown class of your articular cartilage, there may be enzymatic degradation. Okay, so when I say enzymatic degradation, it is the enzyme of our bone body that would destroy the synovial fluid and then the cartilage there. Okay, this enzymatic degradation lead, okay, to the loss of your proteoglycans and collagen, which is found in your cartilage, hence the destruction of your cartilage. There will also be surface ulceration and deep fissures development. Okay, so hence the bottom line is the destruction of the cartilages. Okay, so what do we do for this patient? Okay, pain will be the problem. So we give your acetaminophen, your NSAIDs, and then your COX-2 inhibitors. Then you have your capsaicin, diclofenac sodium gel, and then viscosupplementation may be done. Class, your capsaicin is indicated as a pain gel, and your viscosupplementation is actually a special procedure in a way that your joints are being replaced by a thick fluid. Okay, the thick fluid that is being used is usually composed of hyaline, okay, or your hyaluronate. Okay, recall that your cartilages are usually composed of your hyaline. Recall Anna Fisher would remind you that you would have your hyaline cartilage. Okay, so for that reason, the injection of your hyaluronate is intended. Again, hyaluronate. Okay, the spelling would be Hyaluronate. Okay, the spelling, this is intended to replace or supplement, the joint or the fluids on the joint of your patient. Okay, by the way, let's talk about the signs and symptoms which are classic to these patients with osteoarthritis. So there will be pain, there will be stiffness, and there is what we refer to as functional impairment. In the DIP, there will be the presence of your Heberden's nodes, whereas in your PIP, you will have the presence of your Bouchard's nodes. And then you will have your crepitus, and then you'll have your joint effusion. Okay, take note of that. By the way, when I say DIP, I'm referring to the distal interphalangeal joints. When I'm referring to PIP, I'm referring to the proximal interphalangeal joints. Okay, then your patient again would have crepitus and joint effusion. So this is your osteoarthritis. Now, I would like to talk about rheumatoid arthritis, which is actually the next topic. But just for you to compare the pathophysiology, I would like to discuss this now. So your rheumatoid arthritis is common among ages 30 to 60. It's more common among females. And then, of course, family history. Okay, strong family history predisposition here. Then, you have pollution, smoking, bacterial and viral illnesses. Okay, and still repeating smoking. Okay, although they would say that rheumatoid arthritis is idiopathic in origin and has an autoimmune implications, the above that I've mentioned are the risk factors associated with this. So again, it is idiopathic, not known cause. Autoimmune, meaning it's our own body cells attacking our own cells. Okay, in this case, the joints, okay, or the cells surrounding our joints. So what happens? Okay, there is production of inflammatory and destructive synovial fluid. Okay, there is a production of inflammatory and destructive synovial fluid. This destructive synovial fluid results to collagen breakdown. Okay, later on resulting to edema and proliferation of your synovial membrane. Okay, and then we'll have one term or one problem, which is your pannus formation. Okay, so patients here in rheumatoid arthritis would be experiencing symmetric joint pain in the morning. Okay, especially morning stiffness also, which would last for about an hour. There will be joint pain still, there will be swelling, there will be warmth, and there will be erythema, all signs of inflammation. And there will be Raynaud's phenomenon. Okay, your Raynaud's phenomenon, take note, it could be cold or stress-induced vasospasm. Okay, so there is vasospasm or vasospastic episode. So when I say vasospasm, the tendency of your blood vessels to abruptly shut down or just close. Okay, this would lead to episodes of digital blanching or cyanosis. Okay, so there will be episodes of digital blanching or cyanosis. So class, take note that your rheumatoid arthritis would be systemic in manifestation since we are talking about an autoimmune problem. Comparison to your osteoarthritis wherein our problem is physiologic and degenerative. So what are the laboratory tests that I will be looking into rheumatoid arthritis? Okay, so one, you have your rheumatoid factor. Okay, of course, it would be present. This is classic among your patients with rheumatic type disorders. Then you have your CRP and then your ESR. CRP, C-reactive protein. ESR, erythrocyte sedimentation rate. All of them will be increased. Okay, especially this is an inflammatory problem and autoimmune problem. CBC will not have a diagnostic value, but this is intended only as a comparison. It is intended for future comparison. And then the X-ray, of course, class will show breakdown of the joints, okay, or breakdown of the cartilages also, and then the pannus formation. Okay, so you will not be seeing much on the bone itself, but if you would look at the joint, there will be an evidence of swelling and erythema in your rheumatoid arthritis. So, on arthrocentesis, so when I say arthrocentesis, recall under the diagnostic studies that when we say arthrocentesis, meaning we are getting something out of the synovium, okay, out of the joint. So in this time, if you will be getting the synovial joint, it would appear to be cloudy, milky, and dark yellow. Okay, would indicate that there is a production of your inflammatory and destructive synovial fluid leading towards your collagen breakdown. Okay, so what are our medications for this patient? You will be giving your patients your disease-modifying anti-rheumatic drugs. Okay, in other words, ask yourselves, are these immunosuppressants? Yes, because our problem is autoimmune, we need to suppress the immune system. Okay, that would be the administration of your methotrexate, the administration of your cyclosporin, the administration of your sulfasalazine. Okay, so for this medication, you need to have your CBC checked because of the risk for anemia. And then, of course, class, you'll be dealing with pain still. So you have your NCAIDS and then your COX2 inhibitors. Okay. By the way, there are two kinds of cyclooxygenase or COX inhibitors. You have your COX-1 and your COX-2 inhibitor. Take note that your COX-1 is intended to protect your stomach. Okay, that's why when we are dealing with pain management, we would usually opt for the use of COX-2 inhibitors because your COX-2 inhibitors would not inhibit COX-1. It would only inhibit COX-2, which is in charge of pain perception. Okay? Hence, our stomach stays protected, but we are addressing the pain of your patient by inhibiting your COX-2. This table would compare the difference between your rheumatoid arthritis and then your osteoarthritis. So I hope that by this time you'll be able to have the idea already that when I say osteoarthritis, it's degenerative. When I say rheumatoid arthritis, I'm talking about an autoimmune problem. Okay, so let's talk about osteoarthritis first. So your osteoarthritis, it's said to be insidious, meaning, meaning it has slow onset. Whereas your rheumatoid arthritis may have a tendency to be abrupt. Okay, since your osteoarthritis is a degenerative problem, has a tendency to be slowly progressive, whereas your rheumatoid arthritis is generally progressive, characterized by remissions and exacerbations. Okay, recall that your remissions and exacerbations are usually characteristic of a patient with autoimmune problem. Okay, in osteoarthritis class, there will be presence of pain with activity, and then there will be stiffness following periods of immobility, generally relieved within minutes. Okay, whereas class in your rheumatoid arthritis, the pain is predominant on arising, and it would last for greater than 1 hour and also would occur after prolonged inactivity. Okay, so take note of that. After prolonged inactivity in rheumatoid arthritis, there will be a lot of pain. Okay, whereas in your osteoarthritis, the affected joint class will appear swollen, cool, and bony hard on palpation. Of course, decrease in ROM. Okay, one or several joints affecting would include the hip, okay, the knee, the lumbar and cervical spine, your PIP, okay, your proximal interphalangeal joints, and then you also have your distal interphalanges, and then your first MTP. Okay, so that would be affected. Whereas class, the tendency in your rheumatoid arthritis is that it would appear red, hot, swollen, it would appear boggy and tender to palpation with decreased range of motion exercises and weakness. Okay, so notice the comparison. In rheumatoid arthritis, is a tendency to be red and hot. Whereas class in your osteoarthritis, the tendency is for it to appear swollen, but it would appear to be cool. Okay, now in your rheumatoid arthritis, notice that it would say systemic pattern. Okay, there will be systemic pattern of your PIP, MCP, wrist, and then your knees, ankles, and toes are often involved. So multiple joints in systemic pattern. Going back to osteoarthritis again, you can see that in osteoarthritis, one or several joints only would be affected. Then look at the systemic signs and symptoms. Of course, there will be a lot of systemic signs and symptoms when I am dealing with a patient with rheumatoid arthritis. Okay, because we're talking here about fatigue, weakness, anorexia, weight loss, fever, rheumatoid nodules, and then even your anemia. Whereas, for a patient class with osteoarthritis, the tendency is that the patient would manifest with fatigue. Now, let's focus our attention back to your osteoarthritis. So recall that when I talk about osteoarthritis, here are the following diagnostic tests that can be used to confirm the presence of your osteoarthritis. 1. History and physical examination. Okay, class, from the history, you'll be able to elicit the occupation of your patient, the job background, okay, the possible triggers of your osteoarthritis. X-ray, MRI class would just be intended to determine the extent of your damage. Okay, so MRI in particular will be able to be accurately project an image, okay, that would show plus the damage on the joints. And then you'll have the examination, of course, of your synovial fluid. Okay? Now, what are the medications that we use? So, class, your mild analgesics, such as your Tylenol, acetaminophen, and NSAIDs class could be given to this patient. Okay? Prescription analgesics class, such as your tramadol or opioids, could also be given. So again, class, for the medications, can have your mild analgesics, then your corticosteroids. Okay, corticosteroids because we're talking about inflammatory problems. Okay, again, the COX-2, selective COX-2 inhibitor, and not the generalized or the non-selective COX inhibitor. Then, as I have mentioned, the prescription analgesics would involve the use of your tramadol and opioid. But if you would like to follow the WHO's ladder for pain management, of course, class, we start first with the mild analgesics before we proceed with your analgesics such as tramadol or opioids. And then you can give your topical NSAIDs, and one example of which is your capsaicin. You also have class your diclofenac gel, okay, which are topical. And then you can have your intra-articular corticosteroid injection. Okay, so this is different, class, from the viscose supplementation that I have been talking about. So class, instead of hyaluronate, okay, which is given in viscose supplementation, class, in an intra-articular corticosteroid injection, what is given to your patient is obviously steroids. Okay, class, the purpose of which is to halt again the inflammation. Treatment, regular exercise, but not, of course, the too much exercise. Then weight loss would be recommended. Then the application of heat and ice. Okay, alternating heat and ice, class, to relieve the pain experience of your patient. And then educate your patient on the use of assistive devices. Okay, this is not the time of their life wherein they can deny that they need assistive devices. This time they would need to have your assistive devices. May that be a cane, a crutch, or walker. Because class, without the assistive devices, their risk for fall would be increased. Okay, so they need assistive devices as support. Now, what are the possible surgical interventions that can be done to this patient? One, class, is your arthroscopy. So when I say arthroscopy, a thin lighted tube would be inserted to the joint with the purpose of diagnosing and performing debridement. Now, your osteotomy. For your osteotomy, class, okay, as the term implies, is osteotomy, okay, meaning there will be a removal. So incision into or resection of the bone to realign or to shift the affected joint. Okay, so that's what's done in osteotomy, probably removal of your affected part. Then we have your surgical intervention still. So you have your joint arthroplasty. Okay, so class, when I talk about joint arthroplasty, there will be reconstruction or replacement of your joint. Okay, arthroplasty. So when I say arthroplasty, repair. Then you have your total hip replacement. When I talk about total hip replacement, class, articular surfaces of the acetabulum and then femoral head, okay, is the one that is being repaired. Okay, so class, don't think that it's the entire hip of your patient that is replaced. Okay, class, your hip there would be referring to your acetabulum and then your femoral head. Okay, of course, if the knee will be damaged or if the knee is the one that is damaged, okay, the total knee replacement is also done. So the femoral side is replaced with a metallic surface, and then the tibial side is replaced with polyethylene. Okay. So again, class, take note that the femoral side is replaced with a metallic surface, whereas the tibial side is replaced with polyethylene. This type of substances, class, and their combination and placement would aid in the mobility of your patient. Okay, so take note of that. Now, another procedure, class, that could be done is the use of your prosthesis. So in this case, class, your elbow, okay, your elbow is being replaced by a prosthesis. So this would allow maximum mobility, and then, class, your patient would be having the possibility of movement. But of course, class, the success of surgery would be related to the age also of your patient. Okay, so total hip replacement, class, and total hip replacement, it is the head of your femur and then the acetabulum, which is addressed. So class, your acetabulum is the insertion point of your femur in your hips. Okay, so that's where your acetabulum is. Okay, take note of that. Okay, this one, class, would be the femoral component and then the tibial component of your knee. Okay, so as I have mentioned earlier, the femoral side is usually metallic surface, whereas, class, the hip or the tibial side would be usually polyethylene. Okay, the polyethylene there, class, could be able to act as cushion. So nursing care for a patient with osteoarthritis, we're dealing with chronic pain. Okay, the problem may have been for long. Then impaired physical mobility. Because of the pain that your patient is experiencing, your patient is having inability to have your complete movement. And then readiness for enhanced self-care. Now,
let's talk about your rheumatoid arthritis. When I say rheumatoid arthritis class, the key word there is that it's autoimmune. Okay? Chronic systemic autoimmune disease. It would cause inflammation of your connective tissue. The course and severity are variable, meaning it would vary from one individual to another, and then some references would still say that this is idiopathic. Okay, we only know of the risk factors. So we have the following risk factors. Genetics. Research have shown that people with HLA class would have the higher risk for rheumatoid arthritis. Infectious agents. So there are bacteria and viruses that can trigger your rheumatoid arthritis. Female. Okay, so 70% of people with RA are women. Okay, so class the same that would be, and this occur because of the fluctuation of the female hormones. And then environment, so still the smoking, the pollution, the insecticides. And then for your occupational exposure, that would be your silica and your mineral oil. Okay, that would result to contact dermatitis. And then later on, plus you have your rheumatoid arthritis. So this picture would show to us the pannus formation. So the red on the screen are the pannus with areas of eroded cartilage and bones. Okay, so plus the joint inflammation in destruction and rheumatoid arthritis. So if you would notice the synovial inflammation with pannus formation, and then there is erosion of cartilage and then the underlying bone. Okay, so this is your pannus formation, and then if you can notice the cartilage are already eroded. Supposedly the blue part here, class, okay, the blue part here would indicate the cartilage, but this time there is destruction of your cartilage. Then there is edema and inflammation of the second and third PIP joint of the hand in a patient with rheumatoid arthritis. Okay, so class edema, then you would have the second and the third PIP joints of the hand affected by your rheumatoid arthritis. Class, this is another typical hand deformity associated with a patient with rheumatoid arthritis. Now look at the structure of the hand of this patient and try to find out if what kind of deformity is that. Okay, so class, here is again the pathophysiology of your rheumatoid arthritis. So just to remind you, it's common among females ages 30 to 60, and then this is an autoimmune process. Okay, so class, an autoimmune reaction. Allow me to discuss further on that. So class, it would occur, this type of autoimmune problem occurs in your synovial tissue. What happens is the process that we refer to as your phagocytosis. So class, when I say phagocytosis, okay, phagocytes, meaning it would engulf. Okay, but in this case, class, your phagocytosis would produce enzymes, okay, within the joint. And these enzymes, class, would lead to collagen breakdown, because these enzymes, there's supposed to be no enzyme there or minimal only, but class, there is production of abnormal enzymes, and then the enzymes would break down your collagen. The breakdown of collagen would lead to edema and then proliferation of your synovial membrane. And then ultimately, class, your patient would have pannus formation. So what if there will be pannus formation? Class, the pannus would destroy the cartilage. And this destruction of cartilage later on would also lead to the erosion of the bone. Okay, so what are the consequences on the part of the patient? On the part of the patient, class, the consequences involved are, okay, the consequences involved are loss of your articular surface, so the loss, class, of your joint surface, okay, and your joint motion. Your patient will also experience degenerative changes. These degenerative changes would include muscle fiber undergoing atrophy, class, and then tendon and ligament elasticity being decreased. Okay, so that's what happens in your rheumatoid arthritis. Okay, so again, the drug of choice are highlighted below. As I mentioned, these are immunosuppressants. So what are the manifestations for this patient? So your patient, class, would have swelling with stiffness, warmth, tenderness, pain. Okay, polyarticular pain, class, with symmetric involvement. So the key word there is again symmetric. There is synovial edema. There is limited range of motion exercises. That will be true, class, for all of your arthritis, I mean. Okay, so limited range of motion, because recall it's your joint which is affected. Okay, so for that limited range of motion, your patient would also have weakness, and then you'll have RA-associated deformities. So class, your RA-associated deformities would be ulnar deviation of the finger. There is subluxation of your MCP joints, okay, metacarpal joints, and then you have your swan neck deformity, and then you also have your boutonniere deformity. Okay, so try to find out how does a patient with swan neck deformity would look like and how would a patient with boutonniere deformity would look like. Then class wrist involvement. Once the wrist is already involved, the signs and symptoms would be like of deformity and CTS. Okay, so positive, Valence, and Pinel's sign. So knee, your knee would have swelling, instability, there will be quadriceps atrophy. So class quadriceps is your muscle, contractures, and then there will be valgus deformity. Okay, so they call your geno valgus. Okay, so class geno valgum, I mean. Okay, now for your foot and toe involvement, you have your subluxation, your hallux valgus, lateral deviation of the toes. So take note, lateral deviation of the toes, and then cock up toes. Then for your extra articular manifestations, so when I say extra articular, that would be outside the joint manifestations. Your patient would have fatigue, weakness, anorexia, anemia. Your patient would have weight loss and then low-grade fever. Okay, skeletal muscle atrophy is expected for this patient. Your patient would also manifest with rheumatoid nodules. Okay, added to that class, your patient would have pleural effusion, vasculitis, pericarditis, and then splenomegaly. Okay, so look at it now. Since this is a systemic problem, pleural effusion, fluids in your lungs, vasculitis, inflammation of your vascular or your vasculature, pericarditis, inflammation of your surrounding tissues of your heart, and then you have your splenomegaly, which is the enlargement of your spleen, which is actually classic among patients with autoimmune problem because the cell's body are being destroyed by the body's enzymes also. So splenomegaly. Okay, so what are the complications? Worst complications would be your cerebrovascular diseases, your cardiovascular diseases. You may have your MI, and then your stroke, and then your death. Okay, then you have your increased risk for infection. Then you also have plus rheumatoid arthritis in the older adult is very common because it would increase after the age of 60. Now, diagnosis. We're still going back to history, and we're still going back to physical assessment. Okay, I've mentioned to you rheumatoid factor, I've mentioned CRP, and then you have your ESR. Your anti-CCP blood test class is also used for the diagnosis of your rheumatoid arthritis. And then you have your ANA titer. Okay, your ANA titer. Class, your ANA titer is a diagnostic of your autoimmune problem. So your ANA titer is released once the patient has had an autoimmune problem. Then we can also use your serum complement C3 and C4. Plus the serum complements are increased when we are talking about autoimmune problems. Okay, so they are increased in autoimmune problems. Then you have your agglutination reaction, and you also have your synovial fluid examination. So again, that will be your arthrosynthesis, wherein the synovial fluid will be taken out, okay, and then examined in the laboratory. Only part of it, class, not all of the synovial fluid. And of course, you have your x-ray to see the extent of the damage to the bone already, if it would progress. And then you have your radionuclide scan. Okay, for this patient, our problem is still pain. So that's why you can see the list of medications. Still focus on analgesics, your mild analgesics again. Then you have your NSAIDs, and then your corticosteroids. Of course, since this is autoimmune, we will be able to use your disease-modifying anti-rheumatic drugs. So which is classified into two. You have your non-biologic, and then you have your biologic. So class, for the non-biologic, the options are your cyclosporin, you also have your cyclophosphamide, your hydroxychloroquine, okay, you also have your methotrexate, mycophenolate, and then sulfasalazine. For the biologic response modifiers, which would have minimal side effects compared to the non-biologic ones, so you have your abatacept, you have your rituximab, and then you also have your tocilizumab. What are the complications now because of this therapy? So class, you take note, you are using immunosuppressants, just like using cancer agents. If you can see, some of the medications listed there are actually used for your cancer. Now, when I talk about bone marrow suppression class, okay, so it will be common since we're talking about immunosuppressant agents. So, bone marrow suppression would lead to the problems such as anemia, you would have leukopenia, and then you would even have thrombocytopenia. And then class, for your anemia, you'll have that problem from drugs such as your methotrexate and cyclophosphamide. So they are highly toxic and they can produce your anemia. And then you can also have the gastrointestinal disturbances, especially if you're having your NSAIDs. So that's why the best drug supposedly for pain is the use of your COX-2 inhibitors, selective COX-2 inhibitors. By the way, examples of which are your celecoxib, etoricoxib. So treatment for this patient would involve use of rest exercise, heat and cold, assistive devices and splints, nutrition, and then surgery. For the surgery, you have the following options: synovectomy, arthrodesis, and then you also have your arthroplasty. And nursing care plan for this patient would be focused on readiness for enhanced self-health management, chronic pain, fatigue, and then you have your ineffective role performance. Okay?
Class, that will be the end of the discussion on rheumatoid arthritis and osteoarthritis. Our next topic will be musculoskeletal trauma. I hope that you are laughing a little bit louder and dream a little bit bigger. Thank you for your attention.